Well, today we have a very timely topic. For those of you that have been following trauma and trauma resuscitation as long as I have, we've seen a complete flip in the way we take care of the acutely ill, particularly the exsanguinated patient. When I first trained, we dumped fluid into them like they were just going out of style. I can remember giving people 6, 7, 8 liters of bringers in the emergency room. And that proved to have a set of problems associated with it. So now we've shifted more toward using blood and blood products as our sole resuscitation. That, however, has its own set of problems. Dr. Samra is going to talk about that today. We'll see where this all goes in the future.
All right. Everybody can hear me? Yes? All right. Very good. Thanks for coming. It's kind of Friday noon, you know. All right. So I wanted to start with like a quick reason how we came out with this topic. Me and Dr. Conrad one day in the ER were just talking about, just finished taking care of a trauma patient, resuscitation, and we were just talking about how the pendulum has swung. It was liberal in the past, and then people became a little bit restrictive, went down to 7, and then again it's like people again coming back a little bit, not maybe to 10, but maybe 8 or 9. So kind of evolving topic. So that's why I think the title is, do we have all the answers? And we will see what we find out after this session. So I have no disclosures. I have no conflict of interest. I do want to say that usually this talk is more for adults. I do see a lot of our pediatric friends and colleagues over here. So this is just one of those things just want to say out loud. I would like to, at the end of the talk, I want to cover these 3 objectives I have this afternoon. One is we should be able to hopefully clarify the trigger. Is it the number or the clinical picture of the patient? And the number 2 I want to talk about is the age of the RBC product we are transfusing, the old versus fresh. And the third I want to bring up more for my surgery colleagues or even in the pediatric patient population after surgery. I want to bring up this topic of transfusion-related immunomodulation or suppression. These are my 3 objectives this afternoon. So just to give you the number game here, more than 100 million units of blood products are collected worldwide each year, and 13 million are the RBCs, the reds, in the United States. Then I did my homework with the University Health Blood Bank, and the number I got was that average last year, about 900 units of reds were transfused in 2010 and 17. Yesterday we had a young kid, 14-year-old, a gunshot wound to the chest and the pelvis. On that patient, Rachel was in the OR assisting us. On that patient we gave 20 units of red, 20 units yesterday. So it's a very, as Dr. Weigel said, very important, relevant, important topic. Now we do talk about the word anemia, which is the clinical diagnosis we have. It's a common problem in the ICU setting, and we always talk about the delivery and the consumption. And I have a quick thing on the board over here so that we can connect the dot of step 1 and step 2. You know, and right now most of the people are beyond that, but there's some still with step 2. So we talk about the oxygen delivery, and we have to remember the cardiac output and the arterial oxygen content, which depends on the hemoglobin and the hemoglobin saturation. Sorry, just one quick disclaimer. If you guys feel I'm going fast or you have a question to ask, please raise your hands. You don't have to wait for the end of the talk, so we can be very interactive. And the second is the oxygen consumption, which as a surgeon or as a traumatologist, I would simplify. It's basically the stress, the metabolic activity or the physiological stress, which could be sepsis, could be a polytrauma patient who have extensive surge response. So, however, it has been also noticed that we do also create some anemia, and this is what I learned when I was on pediatric surgery rotation about drawing the blood in pediatric vials, right? Then the whole adult, we draw labs every day. And on the floor, Daniel, we always, when we round, we always say, let's give the patient a lab holiday, so that we don't need labs every day. So anyways, the causes of anemia are the overt blood loss from bleeding, the hemolysis, you see a lot on the bone marrow or the MICU unit, frequent blood draws, which I was talking about, and then the decrease in use of iron, and in kidney patients, we talk about erythropoietin. Now, when we talk about anemia, we go further to the oxygen carrying capacity. We have to, how to treat the anemia is all about to transfuse RBCs to increase the oxygen carrying capacity. And during my reading, I came across that more than 40% of all ICU patients receive blood transfusions, and more than 2/3 of these were not for acute blood loss. So it's a nice, I think, melting pot, this topic of surgical ICU as well as the medical ICU. So 3rd floor and 7th floor interaction. Obviously, 5th floor is there as well for the pediatric patients. So that's important. And in terms of dosing, this is more important for, for the trauma patients, the geriatric patient population, which is 65 and plus. Each unit is about 300 cc's, and be mindful that when you giving it fast, you could also worry about the unintended sequelae of the blood transfusion, which we talk covering later as well. So just some few important numbers given over slowly in a non-traumatic setting over 2 to 3 hours, and an increase in hemoglobin by 1 point. This is the famous, very I'm going to say it's a rounds question. Everyone is asking that 1 unit, how much you increase? So 1 gram per deciliter. And in trauma patients, emergent situations, we use O negative blood for transfusion. So this is just a slide to highlight the stored blood thing which we talked about, because we do know that the stored blood has got some issues in terms of the 2,3 DPG and hyperkalemia, and it's not that useful for the patient. We'll talk about that later. So delivery of oxygen is affected. This is what the books say. There's always a disconnect between what we read in the lab or the textbooks and actually what we find on the patients. So this is the 42 days is the upper limit for the stored blood. So now let's get to the funny part. A little bit of funny, I say, because how the whole thing evolves and moves around. So we are all aware of this famous Hebert et al. The TRISS trial. So this was the clinical question asked in this trial was 7 to 9 versus 10 to 12, and whether it will decrease the mortality. And they studied about 838 patients done in Canada, and they were able to demonstrate in this particular study that yes, there was a decrease in hospital mortality. It was, however, no evidence of active bleed was in this patient subset, and it was a large non-blinded trial, which was the TRISS trial. And 30-day mortality they looked at. However, there were some issues with this study which I found out, and I would like if Dr. Conrad or Dr. Weigel could pitch in, or any of the residents or fellows who are good in having a critique at the study. I felt like there was no subgroup analysis for a brain injury patient in this study. That was my one big thing. And also I felt like there was a concern about the external validity of the study, because only 13% of those screened were randomized in this trial when they were doing the study. So it may not be applicable also to the patients who have a heart disease. So these are the few things, but the thing which I say, it's the TRISS trial, I've been hearing it since I was a junior resident, then I'm the fellow, then faculty and all that. Always TRISS trial they talk about. But then further looking into this, I found these little bit of critiques on this trial. So anyways, this trial started the pendulum to swing from all the way up to, from 10 to 12, back to 7. The famous number 7 came through this trial. And then we talk about the similar corollary, the TRISS trial, which was basically done by, in 2014, Holz et al. And it raised a similar question, 7 versus 9, in a 90-day mortality window. This was partially blinded, done in Denmark, Sweden, Norway, those countries. And it was not double-blinded though. So this was a study done in sepsis patients, in a patient with septic shock. And they noticed that the similar mortality at 90 days to the hemoglobin equal to 9 or more, with 50% fewer units of blood transfused. So this was the TRISS trial we talked about. But however, they excluded the patient with myocardial infarction. Then we had another study which came out for the upper GI bleed patients, and this was done in a setting by Villanova C et al., and in which they looked at single-center, non-blinded RCT trial done similar to TRIC trial for acute upper GI bleed patients, and it was 45-day mortality they looked at, 7 versus 10. They included the patients more than equal to 18 years of age, and the exclusion criteria was massive bleed, or ACS, patients with acute coronary syndrome, or patient with lower GI bleed were excluded in this. And also the scoring system was of less sicker patients in this study. Again, the critique on this one was that the patient with the massive GI bleed and hemodynamic instability were excluded. Obviously, it's kind of difficult to do studies in a patient who are in the sicker spectrum. Then I want to bring up a common scene which I deal with, and I know our medical ICU colleagues also deal all the time, the massive GI bleed in which the whole blood volume is lost in a patient. So I would like to emphasize that your transfusion practice should be guided by the clinical situation. In a non-traumatic setting, we usually, we talk about this famous ratio 1:1:1. That's for more like a trauma patient actively bleeding. But otherwise, also in literature, the ratio 2:1:4 is highlighted if it's not a traumatic setting situation. Because what happens is that patient with trauma, I want to highlight the importance of the new ATLS guidelines. The crystalloids have been decreased from 2 liters to 1 liter now. And the reason for that is because they are showing that if your patient is bleeding, you replace them with blood product. If you give them a crystalloid, you make them more coagulopathic, which we saw yesterday on our patient as well. We were able to control the named vessel bleeding, but the patient was oozy from all over. Even from the gunshot wound was also pouring out serosanguinous fluid, which is coagulopathy. So that's the reason we try to avoid the crystalloid. So there's one message you guys have to take from this session is, in a trauma patient, you know the patient is bleeding, is a hemorrhagic shock, try to avoid crystalloids and give blood products, and activate the MTP, which is the massive transfusion protocol. That's one practical message from today's discussion. Now, in acute coronary syndromes, the survival is improved. It's from 8 to 10 because of the oxygen carrying capacity. That is for the patient with ACS. Coming back to the trauma patient, again, the MTP has to be activated right away. When you know the patient is bleeding, don't waste time. Try to actually say out loud in the trauma bay that please don't give crystalloids. I would like to give blood products. And then the question comes, this is also an interesting topic. Question comes, what do you want me to give? So it's usually the reds, the RBC, which is this topic today, and also the studies are coming out, give plasma first. Also, one of our organizations of trauma nationwide, AAST, is trying to look into some studies, and they're talking about give plasma first as well, and then the platelets. So this is one of those trauma situations. Now, just to talk about a little bit of types of RBC products, the whole blood, the packed RBCs, the gamma irradiated, which is and CMV negative and washed RBCs. Usually, we talked about the gamma irradiated in immunosuppression patients, which is more also like a hem-onc subset and pediatric patients. Now I want to talk about some of the unintended sequelae of giving a product. So we all have talked about this more like in medicine floors. We have seen acute hemolytic reactions, the delayed reaction, and the febrile reactions. But I want to cover two important topics which come a lot in the ICU setting. One is TRALI and TACO. So these stands for as it says over here, talks about the, so this is basically, I want to highlight these two over here. The TRALI and TACO stands for transfusion-related acute lung injury and transfusion-associated circulatory overload. These are the two clinical scenarios which are, I think, commonly seen, and I want some interaction here. Maybe I should talk to Pennington or Todd. Have you guys seen that in your patients when you give transfusion? A lot or not that much?
One time.
One time? Oh, what about?
Pretty rare.
Pretty rare.
A couple cases over the last few years.
And what about our pediatric colleagues? Not much. But do you feel like, Todd, this is underdiagnosed or TRALI?
It may be, and it may just be where we just don't recognize it right away.
Right. Dr. Conrad, what's your take on this?
Probably a spectrum of disorders.
Right.
We pick up the obvious cases and
Right.
probably don't pick up more subtle cases.
I agree absolutely. I think we probably see a lot more trolley than we recognize because we attribute it to ARDS or,
Right.
or just something like fluid overload.
Right. And I felt like going through this, the TRALI and the TACO, you're right, TACO is a little bit more obvious than TRALI, and it's a little bit underdiagnosed thing as well. So, and in terms of long-term transfusion risks are viral infections, some bacterial diseases, and iron overload. Okay. Then coming back to the other interesting terminology which I want to talk about, but just before that, TRALI and TACO. So if you have to differentiate between these two clinical scenarios, so you can obviously look at the clinical picture, the signs of circulatory overload, GVT distension on a patient could go in terms of more of TACO. And then now not for the medical ICU patients, and I have noticed in surgical ICU, I feel like I have used this marker, the BNP, the BNP as a marker. If it's more than 1,000, and I've used that to my advantage, that it could be more like a TACO than versus TRALI, because we're looking at the PF ratio. You can get an echo done, but this is something which I came across as well. And then I want to bring about the third objective which I had was to talk about transfusion-related immunomodulation. So, giving red blood cell transfusion is not a benign thing. It does affect your immune status. It does affect your immunity. And in surgical patients, I see you must have maybe come across or seen if a post-operative patient bleeds and then you give transfusion to that, there's an increased risk of recurrence. This has been, none of our surgeon guys is here, but this is something, a known thing. So the take-away message from this particular discussion is that if you have a post-operative surgical patient who is bleeding, and I know we can go into this normalcy bias, it will stop on its own, plus be mindful that you're giving them blood transfusion, you are decreasing their immunity and increasing the chance of local recurrence. We had a scenario a couple of months back, you must remember, Dr. Pennington, that there was a colorectal patient, post-colectomy, anastomosis done, bled, and it was a staple line, was given at least 6 to 7 units of blood before they did a flex sig, and there was an arterial pumper right at the staple line. So just be mindful of that there is a consequence of giving a blood transfusion, and you can increase the local chance of recurrence of the cancer. So that's why I bring up this the so-called TRISS or TRIM, they call it transfusion-related immunosuppression or immunomodulation. It's a double hit process they talk about, that you have a patient who you may have done has a polytrauma or has a surgery done, and the second hit is the cytokine mediated by the blood products. So this is something to remember as well. Then coming finally to the recommendations, the restrictive RBC transfusion 7 versus 10 in hospitalized adult patients who are hemodynamically stable. So this is a strong recommendation, moderate quality evidence. So the spectrum is again, the whole thing is to 7 in a stable patient though. However, the number I found out a little bit further, 8 for a patient who's going orthopedic surgery, cardiac surgery, or has a pre-existing cardiovascular disease, which means there's a concern about oxygen carrying capacity. Now, myself as a surgeon, I admit that I sometimes underestimate the blood loss, but not to the extent of my orthopedic colleagues. You know, they're not here in the audience, but with no due no due offense to them, I have talked to them face to face as well. You ask them how much was the blood loss, they will say about 200 cc's. Actually, it's almost close to maybe 600 to a liter. So almost like highly underestimated by them. And me as a general surgeon, I also tend to underestimate the blood loss. So, and I saw that in the literature they're talking about maybe 8. It's called anticipation, because you will know that they may lose the blood for a procedure. So this recommendation of 8, I think is very relevant for a pre-op workup. We had a scenario in our ICU, a lady with shoulder and scapular fracture who needed to go for surgery. One of my colleagues, Miss B, is not here right now, but we were taking care of the patient, and we did follow this recommendation on that patient to bump up the hemoglobin to close to about 8, more than 8. She was running around about 7.2. So that's another recommendation. And the last one I have over here is restrictive transfusion is likely comparable to 8, but we don't have a randomized controlled trial evidence for all patient categories. So I go back to my previous reason to pick up this talk, and the conversation I had with Dr. Conrad was that how the 7 and the 10, and maybe the pendulum is coming slowly, it was back to like 8 to 9, or so kind of one of those things we're talking about. But be mindful that this is not relevant to a patient who has got acute coronary syndrome, severe thrombocytopenia, or chronic transfusion-dependent anemia. So these are the subset of cardiac coronary unit patients, or hem-onc, bone marrow transplant patients, so that's not relevant for that. Let's now talk about RBC storage. So I came across this talk about old blood, fresh blood, and the definition-wise, the fresh blood is less than 10 days. This is what I came across in the discussion, going through the literature. Now I found out that 13 RCTs have evaluated the effect of RBC duration of transfused RBCs on patient outcomes, and 7 since 2012. 7, so almost 1 every year, maybe 2018 right now. And then also the interesting part is that there's no current formal guidance on the optimal length of RBC storage prior to transfusion. And also the recent paper, the RCT done, demonstrated that fresh blood did not improve the clinical outcomes. So it was interesting to see what we read in the, I think there was this topic was also brought up in the journal club. It's interesting to see what we read in the books and what is more physiological versus what's actually practical. So this is about the RBC storage. These are my references, and just a quick trick over here. What does TRIM stand for? I can ask that to my colleague, Pennington.
Transfusion-related immune
modulation. Yeah, cool. Just to check whether you're paying attention or not. Just kidding. So anyway, I want to go back to my initial objective over here, and I hope I was able to cover these things. And I go back, again, I want to ask the audience, so the trigger, a number or a clinical picture. So how many hands will go for a clinical picture and not a number? So I think mostly, so we kind of agree on that. So I feel at least one objective is met. The age of transfusion of the RBC. We all know that it's really all over the place, so really we don't know. And you guys already got the TRIM, and I wish my more surgery colleagues were there. I did invite my surg-on colleagues, but they're busy, it's Friday, you know, so they're busy. So, but that's something I want to tell them, and as a traumatologist, we have already on the same page, me and the ER colleagues, that the patient is bleeding, please give blood products. But I wanted to highlight this post-op transfusion practice, which is very dangerous. Because if the patient is bleeding, it's a surgical, please go and fix it. Don't give the blood transfusions and have the unintended consequences of the local recurrence and the side effects of the transfusion as well. This is all I have for today. Thank you.
Studies you cite that show that fresh blood, less than 10 days,
Right.
is no different. But it's no different compared to what? 20 days?
Yes, that was
30
the,
days,
yes.
22 days?
It was 20 days to 3 weeks. And then also I found one a little bit later.
Because the storage lesion is something that progresses over time. So if any of those studies looked at actually not just comparing like old versus new, but actually looking at the effect of time as an independent variable, as a continuous variable, saying increase in risk is such and such as you go to 30 days, 40 days, and so forth.
Did not come across that, or did not look at that, but I just looked at the definition was very variable as well, like 10 days versus like 3 weeks.
We store blood up to 42 days theoretically, but we'll
Right.
try to find 42-day-old blood in our. It's not. You know, you're in a trauma center or a major hospital.
It won't be.
You probably won't see anything over about 3 weeks old.
That's a good practical point.
So I'm
Yeah.
wondering if those studies are biased by the fact that it's really not old blood they're comparing it against, but maybe a little older blood. Just curious.
Yeah, I can actually look back into that data set on those studies. It could be a good project for here as well
Yeah.
to see. Cool. Any questions, guys? I hope. I don't think so. We have all the answers. Maybe I created some more questions for you guys. Yeah. Thank you.